great honor that Dr. Bakshi and all the luminaries, they are chairing my session. And as a student, I have been seeing her, inspired by her, impressed by her. And it's a treat if she is chairing your session. The introduction she gives you just puts you on the cloud 7. Thank you very much for that. And before I start, I would like to say one thing, that I'm not a geneticist. I'm a gynecologist. And why I have chosen this topic, because I'm speaking on behalf of the gynecologist, knowing the limitations beyond which we are not able to understand the genetics, or we are not able to remember. It's so confusing. It's so, in day-to-day practice, if we start applying genetics, it's actually becomes a very, very confusing state. So you do need a geneticist, but the important part which I want to bring is that we cannot escape it any further. It's there on the wall, and we have to learn it. How much we can apply, it all depends how we are interested in it. So the objective of this talk would be, number one, when to suspect genetic disorders, few basics, which MBBS basics, I think I would put it MBBS basic, we have all read it, but we should remember those and try to apply clinically. Then what to expect and what not to expect from genetic workup and counseling, and what reproductive options do we have. So what would you do? You have, see, as an obstetrician, what we have been doing so far, a patient comes with a history of one stillbirth, one neonatal death. What do? We go through all the tests, the general workup, the obstetric history, and then maybe patient also adds that there was some delay in labor, and then you just get confused. Yeah, we don't know what's going on, and then you just will try to do best during the delivery, and this is what we have been doing so far. This is one patient who comes to you at 12 weeks. She has a high-risk dual screen. Her both male nephews suggested that they were mentally retarded, so they were presumed that they had Down syndromes. But then the workup was done by a geneticist, and she found an X-linked pedigree. And so she did a workup for Fragile X premutation, and the story actually changed. So we could have, I had not referred this patient to a geneticist, I would have passed it off as कि हाँ brother के दो बच्चे को Down syndrome है, parents का karyotype normal है, and I would have said yes, everything is fine. This is again one patient with stillbirth, one neonatal death, one infant death, and again we are stuck, and now we do get some answers if we refer these patients to the geneticist. So this patient had actually turned out to have two genes which were lethal and which could have created problems. So why there is concern for genetic disorders? Most of the disorders are lethal or lead to mental or physical serious handicaps, and there is no curative treatment, or treatment is costly with side effects. Actually, if we compare the cost of the investigations, it's no match to the lifelong cost for the care of these babies. The concerns of the family, why did this mishap occur? Will it occur in family or in my family, or what are the chances of recurrence? Can we prevent recurrence? So it is important that clinicians are able to identify the red flag signs of genetic disorders, counsel them, and refer them to a geneticist for appropriate investigation and advice where available. What I would stress here is the referral is very important. Most of the times, many of the times, some of us who have started, more interest in genetics, but I'm sure I tried. We cannot handle it. Unless you get a proper training in genetics, you cannot handle it. So the another thing which once I got interested in genetics, the another thing which shocked me was the disease burden. 1% of all live births and 20% of infant mortality, 20%, which is actually very high. We do get bad obstetric history, we just label it as BOH. The baby died at 6 months of age, 7 months of age, or at 5 days of age, and we just dismiss, we are not able to find the cause. So 20% of infant mortality is because of genetic diseases. 20 to 30% of autism spectrum are there, and more than 50% abortions, I think that part we do know, and 20 to 25% unexplained stillbirths, again maybe because of the genetic deaths, genetic causes, and many cases of birth asphyxia. We have been blaming the obstetrician for all the birth asphyxia, but actually there could be some genetic disorder which has presented to us as well. They do get during labor also they are troubled, and then after that they present with intellectual disability. So just briefly, prevention of genetic diseases. We know we cannot treat genetic diseases, we can only support these children who are born with genetic diseases. The one type of prevention is antenatal diagnosis. We diagnose and then we abort, and the ultimate kind of prevention is that you can do a pre-implantation genetic testing and choose the normal embryo rather than aborting an abnormal fetus. You can choose a normal embryo. So just few basics: the human cell, the chromosomes, you know, and aneuploidies. I'll just rush through just to remember the terms. Aneuploid is this numerical differences, like they may be trisomy, monosomy, if the whole chromosome is lost, or partial aneuploidies like deletions, duplications. These are commonly found in cases of recurrent abortion. And structural abnormalities like micro deletions also may be there, and micro duplications also may be there. And then single gene disorders, the classical Mendelian inheritance disorders like variations in single base pair, autosomal dominant recessive. So again, we have all read about this Mendelian inheritance autosomal dominant disorders, that 50% would be affected and 50% would be normal. But when we come to a pedigree analysis, it's actually becomes quite troublesome to diagnose from the history and pedigree what kind of inheritance this family is having, and when we are counseling a patient, to give patient the chances of recurrence, again it becomes actually not very simple. It's simple in autosomal dominant, but X-linked and autosomal recessive, again you get very confused that what are the chances of having a normal female baby, carrier normal baby, or male normal. It's better to have these charts with you so that you can counsel them properly. And then mitochondrial inheritance, this is all again linked to females. This is also coming, and there are geneticists, they can clinically pick up these mitochondrial diseases, and they go for this test for mitochondrial assessment, mitochondrial gene genetic assessment. Then type of the genetic testing, what we are having: cytogenetics, what we have been knowing for quite long, molecular cytogenetics, and molecular genetics. I think this part all of you by now know, because lot of importance is being given to genetics, and lot of lectures are also there, that the karyotype is only for numerical abnormalities like aneuploidies and all it can detect. Then microarray, again it's a more detailed analysis, and it can pick up duplications and deletions also. And microarray is the test now which is to be done on products of conception. So my karyotype, generally failure is there, the growth of POCs is not there, so it's not very recommended for POC, although for adults peripheral blood karyotype is the standard method still. And molecular test, the NGS and other tests, they are for genetic disorders. genetic testing techniques, cytogenetics, karyotype, molecular genetics, array CGH, QFPCR, MLPA. We know by and large that these are required, but at the same time, on behalf of the organizer, I would like to welcome Dr. Chandravati and Namaskar, Madam. So, again the test, molecular test, Sanger sequence, clinical exome, whole genome and mitoexome, they are actually to be advised by the geneticist. Again, I would say that please do not venture beyond your domain and let the geneticist decide what is the best test, because the interpretation of test also is very difficult. They have to go through all the genes, whether that matches their clinical judgment or not, and then only pre-test counseling, post-test counseling. It's a real elaborate kind of counseling which they have to do. So these tests, and till now, again, every time I have to ask my geneticist, इसका कौन सा टेस्ट कराना है, इसका ये टेस्ट क्यों नहीं करा रहे, because I had thought के इसमें clinical exam होगा, नहीं whole exam करना है. If I said नहीं ये तो MLPS से हो जाएगा, तो Sanger से ही हो जाएगा. So I mean it's actually very confusing. Maybe after a few years when we are using it more and more, we will also learn the basics of which test to advise in which condition. But right now, I think most of us should rely, we should have a good geneticist in our team, and then we should work with that. So how do the geneticists work? They take a history, the pedigree is their main tool, and clinical examination and lab tests. And the counseling of the patient is to be done to understand the nature of the disorder, prognosis and management, inheritance and risk of recurrence, reproductive options, and they have to give them the psychological support the patient need. And they are part of the PGT team, and in PGT team they do pre-PGT workup, interpretation of reports, and help in the decision making. So preconceptional genetics, when to refer for genetic counseling: advanced maternal age, consanguineous marriages, personal family history of infertility, recurrent spontaneous abortions, unexplained stillbirth, neonatal or infant death, birth asphyxia, multiple CMF. Previous child or close relative with developmental delay, autism, short stature, malformations, epilepsy, muscle disease, hemophilia, thalassemia. History of cancers in multiple family members, and screen positive for thalassemia, which is very common these days, that you may find some couples with both partners having positive for thalassemia screening. So male infertility, lot of cases we all know that directly are related to genetic causes. Almost 5% in oligospermia and 15% in azoospermia, maybe because of genetic causes like Klinefelter's, mixed gonadal genesis, translocation carriers, microdeletions. Then single gene disorders, cystic fibrosis and congenital absence of bilateral warts disease. This is actually very common, and a lot of IVF and with PISA and TISA is done with for these conditions, and so these couples do need genetic counseling and screening before going for IVF. Kallman syndrome, the Immortal-Cilia syndrome, androgen insensitive syndrome, you all see. Then genetic factors in the female, Turner syndrome. Turner syndrome has again become amenable to IVF with ovum donation, and they do have their own risk, so you do need to confirm. It's not just any patient who comes with primary or secondary amenorrhea. Clinically you suspect Turner and you don't do a karyotype, because Turner itself has a lot of problems during pregnancy, so you need a genetic workup for these girls also. And then translocation carriers with RPL, and single gene disorders, Fragile X again may lead to premature ovarian failure, and this is one of the recommendations these days. Galactosomia, congenital adrenal hyperplasia, Kallman. There are other many X-linked diseases which may present as infertility per se, and carrier screening is to be done in healthy individuals who are heterozygous for a defective gene, copy of an autosomal recessive or X-linked condition. Why we need carrier screening? Because most people do not know they are a carrier for inherited gene disease until they have a child with the disease. It is a genetic testing used to identify individuals or couples that are at risk to have a child with such disorders. Thalassemia screen is a classical example of carrier screening, which now is recommended for each and every patient who is planning or is pregnant or is planning to get pregnant. Once identified, carriers of these disorders can be guided for their reproductive risks, reproductive options, and help to make informed choices. So this is one, the carrier screening has been divided into many such options, tier 1, tier 2, tier 3, which tier 1 contains the most common, tier 2 contains the least common, and then finally it is the directed screen. If the geneticist suspects that there is a disease, then they will do a directed screening of the carrier. So this is the first case where there was a neonatal death on day 5 of life. Uneventful antenatal period followed by full-term CS, 3 kg, cried immediately, no feeding difficulty. The baby got lethargic on day 3 of life, stopped feeding, started having partial seizures, TLC CRP significantly raised, sepsis like picture, expired with a diagnosis of neonatal sepsis. When this was a very odd case and this patient just refused to accept. Actually, this patient herself refused to accept that how can this happen, and she came to us for genetic counseling. And in chromosomal abnormalities may be there in 6 to 17% of such babies. Single gene disorders in 5 to 10%, and maybe this is an underestimate because genetics is an evolving disease. More and more genes are being identified, so this may be an underestimate. Malformation, single or multiple may be there, and fetal disruption or dysplasia syndromes may be there in less than 1%. Neonatal sepsis must be a diagnosis of exclusion. I mean, this is the scenario is changing. We thought that sepsis is the commonest cause, but it should be a diagnosis of exclusion if there is no setting for sepsis after ruling out genetic disorders. So in this couple, the screening was done and she was diagnosed with citrullinemia, and then this patient is autosomal recessive. I'll run through this. And she had genetic counseling, and then reproductive options was given. So she can have a planned spontaneous pregnancy followed by prenatal diagnosis, and this patient did conceive spontaneously next time. Amniocentesis was done and the baby was normal, and then next time she had a healthy baby. Or she can opt for IVF PGT-M because that is also easily diagnosable, and or the third option when they can have an alternate gamete, or finally adoption. So this patient again, like I said about Fragile X, she's due for her amniocentesis soon, and then we'll know what is to be done for this patient. And again, this patient also had one metabolic disease diagnosed, who had one stillbirth and then one neonatal death. And this patient again, we have given her options for PGT-M or to go for, because antenatal diagnosis may not be that, because here 2 genes are involved. So there may be problem. The PGT-M, you know, A, M and SR. M is primarily for monogenic disorder. The basic advantage of PGT is that you can test multiple pregnancies at single sitting. So patient doesn't have to go through the trauma of so many pregnancies to know whether the baby is normal or abnormal. And second, you are choosing a baby, normal baby, not discarding a abnormal pregnancy or aborting an abnormal pregnancy. So I will just rush through these slides. The setup, it's a huge setup. And for PGT team, you know, you need an ART specialist, geneticist, counselor, embryologist, and a good genetic lab to complete the cycle. And to conclude, I would like to say that genetic diseases can't be cured, but definitely they can be prevented with modern technology, and we need to be aware I think today is the need when all the gynecologists should know when to consult a geneticist, what tests to be done, the basics, how to counsel the patient, the basics of counseling, and then maybe choose the reproductive options which we have now. Thank you very much.